Welcome to Stand Up for Doctors. I'm your host, Kim Downey. Thank you very much for joining us. I'd like to welcome back Dr. Jose Mendez. Thanks for joining us today, Jose.
Hi, Kim. Thanks for having me.
Hi, you're welcome. I'm very happy to have you back.
Thank you very much for inviting me.
Okay, sure. So I will introduce you again as I did last month. Dr. Mendez is a pulmonologist and is board certified in internal medicine, pulmonary, critical care, and sleep medicine. As the medical director of the Sleep Disorder Center, Dr. Mendez takes a special interest in providing a comprehensive sleep evaluation and treatment for children and adults with complex sleep conditions. And when I had you on last month, we talked about doctor stress and sleep, and that's episode number 60, and that's great. So I wanted to spotlight that. And I wanted to have you back as today you'll offer an overview of various sleep disorders and when to refer patients to a sleep specialist such as yourself. And that information will be helpful to doctors and patients.
Mm-hmm.
And the last time I had you on, I gave a shout out to my own doctors, as you know, almost all of them. And today I'm going to give a shout out to Ann's Place, our local cancer support center, and Kevin Barrell, a social worker at Ann's Place. And Kevin facilitated the Zoom presentation where you discuss sleep issues for an audience of patients with cancer. And I thought it was great. And that's why I reached out to you. And I know you gave a similar presentation back in 2021, and I'm so grateful for everything Ann's Place has to offer. And I myself had struggled with some unintended consequences from my first cancer surgery, and Kevin was absolutely amazing. He helped me with a lot of things as I had a crazy summer that year, leading to being diagnosed with cancer 2 more times. And I've been participating in his midweek mindfulness group, writing groups, a few art groups, and I even took some piano lessons, and it all helped. So here's to Ann's Place, or I wouldn't have met you.
Thank you for it. They do wonderful work.
Yeah, absolutely. So I always start, and I'll give you an opportunity to share this time what you'd most like our audience to know about you as we begin our conversation.
Well, I would like to share. I had a great time with my family in Argentina. I love walking, and I had the pleasure of walking with my brother's dogs in a beautiful environment in the country. So I had a great time relaxing, and I had some good sleep too. So with that, I'll be happy to start if you want me to, or unless you want to start with a question, or if you had any questions from the.
Well, at one point, I do want you to answer because actually I read you contributed to a New Vance newsletter about sleep,
Yes,
and I read it.
yes.
And one question that I have is, how does the blue light emitted from electronic devices negatively impact the body's production of melatonin? I was just wondering if you could speak a little of that because I don't really know the mechanism.
Absolutely. So I think, when I think of sleep disorders, I always pause for a second, and I think about, patients think of unusual stuff. And the truth of the matter is that the majority of the sleep disorders that we suffer from, and I'm talking now as physicians, but also patients, are mostly self-inflicted. So many of the conditions that I treat are self-inflicted wounds, and one of which is light exposure. We live in an environment where we have light all day, and if we let it, it could be 24/7. It comes out of iPads, kind of iPhones, and a wavelength of that equipment is blue light, which is particularly bad for our brains and our sleep because it affects our circadian rhythm, which is our brain capacity to fall asleep at a certain time. And the brain does that by by naturally, when we go to bed, the lights is down, right? If we respect that and we don't use a laptop or an iPad, our bodies will produce a chemical called melatonin. And when we get ourselves exposed to the laptop or the phone or the iPad in the middle of the night, or watch the news in bed from the computer, what we're doing is we are actually hijacking our own internal mechanism to fall asleep by shutting down the production of melatonin. So much of what we suffer from is overstimulation of social media, computers, iPad, TVs, and the light is particularly bad for our production of melatonin, and that's the way it affects us negatively. And what it will do is it will make it so much harder for you to fall asleep naturally that you will need more time, and people will get frustrated and stay in bed and maybe reach out for a glass of water, come back to bed, and there becomes this dance between back and forth the kitchen and the bedroom. And I think a lot of it could be eliminated if we are regimental about our habits and we eliminate the lights in the evening. You know, as I said, as I started off this, like saying a lot of this is self-inflicted. The majority of our patients, the patients that I see in the clinic, come in with excessive daytime sleepiness. They come in very, very tired. And the doctors refer the patients to me looking for an unusual sleep disorder. I can't tell you how many times I find that many of these people are just sleep deprived. They're just not sleeping enough. And when I ask simple questions, such as what time are you going to bed? How much coffee do you drink? What do you do before bedtime? I realize that a lot of this can be fixed by simple things like avoiding caffeine, for example, which is something that we enjoy. I love coffee myself, and I'm not saying that we shouldn't drink caffeine or a cup of coffee every once in a while, but if you have insomnia or if you're someone who suffers from insomnia, caffeine should not be part of your daily supplements or your drinks, right? Or any caffeinated drinks for that matter. So a lot of the sleep disorders that I see in the clinic are, as I said, self-inflicted. And the majority of this has to do with light exposure, overstimulation, excessive use of caffeine or alcohol for that matter, particularly in the evening. And simple fixes like avoiding alcohol in the evening, avoiding caffeine during the day, having a regimen of going to bed at the same time, that is all it takes. There is no need for complicated or unusual testing or sleep tests or anything weird. I go over with my patients about all of their medical history. Many of them have conditions that can prevent them to fall asleep naturally, like pain, or they may take a medication that will get them up at night, like a diuretic. That's a very common issue. But a lot of it can be eliminated and fixed and completely normalized by changing a few habits. Few things can take us a very, very long way without, and I emphasize without, the need of any medicines. Although I'm not opposed to using medicines for sleep, the majority of the work that I do is in the taking of the history by just asking simple questions and then eliminating or replacing some habits. Now, sleep in doctors is particularly affected by sleep deprivation, I think, because the nature of our practice, myself included, that we function in a shift mode, is such that we all suffer from a degree of sleep deprivation. And there are different types of sleep deprivation. There's those of us who suffer from acute sleep deprivation if we stayed up all night, if we had a busy night in the ICU. But there are others, such as primary care doctors, many of them could be hearing this, that stay up at night working on their charts,
Right.
and they have to complete their medical records, and they have to get up early in the morning, like 5 or 6, to go to the gym because they know that exercise is important. So at the end of the day, when they think backwards, and I have many of my patients are doctors, when they think and they reflect on their own habits, they realize that they didn't sleep much more than 5-6 hours per night. And our bodies need 7-8 hours per night. And if you don't do that, eventually you're going to pay for that. In a way of feeling tired, in a way of finding yourself having difficulties with concentration. You could get headaches. You could have trouble losing weight. You could have troubles with your hormones, particularly insulin is one that is particularly studied in diabetics. And we know that patients who have diabetes have a particular difficult time controlling their glucose because they have something called insulin resistance, which is when the insulin doesn't work as well. And that is something that is particularly affected by sleep deprivation. So sleep deprivation is my favorite topic, is the one thing that I enjoy talking about the most, because it's such a low-hanging fruit for patients and doctors, and is something we can intervene and correct very quickly, right? So my take on this is, eliminate as much as you can the light from your evenings. The opposite is true on the other part of the day. When you wake up, you need to see tons of light, right? Because that's kind of basically tell the brain it's time to wake up, it's time to get going. I in the summertime I enjoy having a little walk with my dog in the early morning hours when the sun is coming up, because I just enjoy having that feeling of being outside and even in your backyard, and seeing the sun in your eyes, and first thing in the morning. That's something that I like doing. In the wintertime, it's tougher because when you get up in the morning and it's not as much light out there. But if you can take a walk, if you have the benefit of taking a walk and exposing your eyes to sunlight, bright sunlight in the morning, that's absolutely fantastic for your sleep. But in the evening, you have to be particularly careful avoiding artificial light. And blue light being part of it is part of the light that it's one of the wavelengths of the spectrum of light. Is one that is particularly bad for your eyes and for your circadian rhythm. So that said, we do see in our clinics patients that snore, and that will be my next topic, which is obstructive sleep apnea. And sleep apnea is a condition where you have episodes of interruption in your breathing in the back of your throat, and usually happens in patients that are obese, but not always. And it's important to emphasize that people thin, including myself, I have sleep apnea. I'm not obese. I'm overweight, but I'm not obese. And I do have sleep apnea, and I wear a CPAP machine. And I sort of self-diagnosed by virtue of just listening to my wife saying, you snore really loud and you make these noises at night when you stop breathing. And I'm thinking, that's exactly what I treat. That's my field. So I investigated myself. I did a sleep study, and I found that I had sleep apnea. And it really changed my life completely. After that, my days turned around. I was more awake and more alert. Every time I woke up in the morning, I felt that I had never gone to bed. It almost feels like you have this grogginess, this feeling that you have not recuperated from your previous day. And after I started CPAP, that changed dramatically. In addition to which, I had an improvement in my blood pressure that was very noticeable. I do wear a continuous glucose monitor, and I'm telling you this, Kim, kind of to give myself as an example, because I know that there may be others out there that go through the same.
Absolutely.
I don't mind sharing that I have a little bit of insulin resistance and pre-diabetes, and I wear a continuous glucose monitor on me. It's one of those little tiny devices. I have nothing to do with the companies that make this, but I find them extremely helpful when you are looking at your diet. But I use it also as a way of assessing my own sleep or lack of sleep. So I can tell that when I'm on call and I'm sleep deprived, my glucose levels go up. When I'm stressed, my glucose levels go up. Certain foods, my glucose level go up. And when I started using my CPAP, all of a sudden my glucose started to get better too. So I think you could, in a way, I was doing a little bit of an investigation on myself of how those things will affect you. So not sleeping enough and having obstructive sleep apnea, which is this snoring condition, which is, by the way, is very easy to diagnose. It's a clinical diagnosis, but also we have home testing that can be done in the comfort of your home that can tell us on a single night if you have it or you don't. Is extremely important to control our metabolic conditions, such as diabetes and insulin resistance, and our high blood pressure. So one of the main messages that I always like to get across when I give lectures about sleep disorders is how critical sleep, particularly lack of sleep, and obstructive sleep apnea as a way of two main diagnoses. How critical are they in the management of very common conditions that we see out there, diabetes and high blood pressure?
Mhm.
So I'm going to stop right there and ask you, Kim, do you have any questions, anything else you wanted to know or you
Yes,
heard people asking?
sure. So when I've spoken with patients also around the country, because I speak to patients as well as doctors,
Yeah,
and now, of course, visits are very limited. With a physician, they're limited often to
yeah,
anywhere from 10 to 20 minutes. So when a patient goes to see a doctor, sometimes it's a specialist about a specific issue. They sometimes would want to bring up other things, right? And now
yeah,
in these days, there just isn't time for that. So when patients share that they're having trouble sleeping, specialists always say talk to your primary care doctor. Often when they go to their primary care doctor, that is also for like another reason. And then the primary care doctor wouldn't have time to really dive into sleep issues. So they just might offer medication. And I know you and I have had a
yeah.
couple conversations where in general you try and you're able to avoid medication many
Yes.
times. So I guess this would be for maybe primary care physicians or any physicians. What is there a few questions you would recommend they ask
Yeah,
their patients, and how would they know
yeah,
how when should they refer them to somebody like you?
yeah. I think that that's a great question, Kim. I think that I know that they're limited with time, but if you understand how critical sleep is for pretty much every other condition that they are treating, they should be starting by asking simple questions such as, what time are you going to bed? What time are you getting up? And having a mental calculation of how many hours they sleep. Again, an adult should get 7 hours of sleep. That's the healthy time. In a regular manner, going to bed at about the same time and getting up at the same time. And then, do they snore? Do you snore? Yes or no? Does your wife or partner or husband tells you that sometimes you stop breathing or have pauses in your breathing? That's a very important question. And do you feel sleepy during the next day, or do you feel tired to the point that you feel like you never went to bed? One of the most critical things to identify the sleep disorder is how you feel in the morning when you just got up in the morning. If you feel well when you get up in the morning, that means your sleep was adequate, was restorative, it made you feel well, there's no concerns. But if you wake up in the morning and you feel as tired as you went to bed, there's probably something wrong with your night. And that's when you start this detective work. But very simple things like, do you stop breathing at night, or do you have pauses in your breathing? Do you snore loudly every single night? And are you overweight? I mean, that's part of the physical exam, but it's a question, if someone wants to know what the cutoff is, anything over a BMI of 30 puts you at a very high risk of sleep apnea. And if your wife or your spouse tells you that you stop breathing at night, that's probably it. I mean, it's as simple as those simple questions. I always like to get a sense from patients as to what medications they take,
Mhm.
because many of the medicines that people take for other conditions, such as depression or anxiety, could make sleep in a way different and could make your days a little bit different in the way that your sleep may not be as effective. So that's a good starting point, but it takes only 5 minutes or maybe even less than that just to get a sense of where you're at. And the question of when to refer, I think that many of my primary cares in the community are very well educated now in sleep disorders because I've taken a lot of time in educating them. So they actually do ask for sleep testing themselves. You could ask for a home test being a primary care doctor, but I think that whenever there is that question, I get up in the morning and I don't feel right, I think they should at least consider the possibility of obstructive sleep apnea or other sleep disorders, and you know, that should trigger, if it's not something related to an acute issue, like let's say I went to Europe, I came back, I'm jet lagged, I'm not sleeping well, or I'm going through a difficult time with my finances and I'm depressed and I'm anxious and I can't sleep because of that. If it's not something acute and circumstantial, and it's more than 3 months that people have suffered these symptoms for them, I think it's time to at least consider a phone call or a referral to a sleep doc. I know that many of them have a million conditions to treat and they cannot take another one, but sleep should be part of the usual questions in primary care doctor's office. I can't emphasize that enough. If your doctors are not asking you questions about sleep, you should be voicing them to them and saying, please, can I tell you about what's going on with my sleep, because I think this is important. If your doctor treats you for high blood pressure, if your doctor treats you for atrial fibrillation, sleep should be part of the questions every day.
Mhm. Hmm.
So
So some of it is, like you said, even when we started this conversation, good sleep hygiene. When we spoke in our last conversation, you had said some things that doctors think to ask their patients, they don't think of for themselves, right? So they
correct.
might be able to rattle off or ask their patients about good sleep hygiene when they aren't following good sleep
Yeah,
hygiene themselves,
yeah,
and you're finding that that's some of the issues. So if a physician does ask their patients about sleep hygiene and it seems like it's pretty good, would you, and they can't figure it out,
yeah.
would you recommend that they be referred to someone like you before they put them on medication?
Absolutely. I think it's always a good idea because medicines for sleep have a very, very, they have a value. They're indicated for some people that, we have to rule out sleep apnea, for example, before you give an hypnotic. Let's say a very simple mistake will be if somebody has obstructive sleep apnea and they're stopping breathing at night, putting them on a medicine to sleep will only make it worse because those apneas will get worse. That will be a very simple example. In addition to which, many of these medicines have side effects. They interact with other medicines. They have very serious, I have some concerns with dependency. And that's may be psychological dependency, or could be real chemical dependency in the case of benzodiazepines, for example. So I tend to shy away from medicines if I can avoid it. I use a lot of them, but that's because of the nature of my practice. I tend to deal with patients that absolutely may need them. And I have done my work in asking questions and ruling out everything else before I get to the medicine and trying everything else, which the literature suggests that very clearly in someone who has insomnia, even in the very severe cases, doing behavioral therapy, which is talk therapy and assessing their needs and looking at sleep hygiene, are much more powerful than any medications in the long run. It's just that it takes longer and it takes more work and more patience and cooperation from the patient. So I always like to ask the patients that they need to be my partner in this and they need to engage. And the more engaged they feel, the more empowered they feel. And the more empowered they feel, the better they do. And the better they do, and they keep on going to the point that they come back and say, I can't believe that I'm sleeping without any pills.
Mm.
And all it takes just to partner up with your patient, right? So I think that the benefit of also seeking out for help in a specialist is that we do have the time carved out in the meeting to exercise those behavioral techniques that we are trained for. And if we are not, then we can refer you to a psychologist that can do that work for us.
Mhm.
But the bottom line is those behavioral techniques are much more powerful than any pill.
No, that's great to know. So two more questions that I have is in any most healthcare systems that have a pulmonologist such as yourself, is there usually someone on the team that is relative expert in sleep medicine?
Yes. Yeah. So in general, sleep medicine is part of the pulmonary practice for most places, but not all. We do have the benefit of having a multidisciplinary group here. We have a neurologist that is also Dr. Guardia, who is a neurologist, and he is a sleep board certified doctor.
Hmm.
So whenever we have patients with neurological conditions that have sleep disorders, we tend to refer those patients. And we work together with dentists, for example, that actually are sleep educated and trained. So having a psychologist, a neurologist, a psychiatrist and a pulmonologist makes up for a good sleep team. But in general, most practices have sleep doctors that are trained in pulmonary medicine, and that's by virtue of dealing with sleep apnea, which is perhaps the most common sleep disorder. But there are other conditions that have to do with neurological diseases. I'll give you a quick example. Restless legs is a condition that I treat, but many neurologists have treated for years, which patients are very restless during the night. They move and they cannot settle down and sleep. So in general, sleep medicine is a specialty on its own, and is a standalone specialty, but many of us are actually pulmonologists by training. A good other half is neurologists, and psychiatrists will complete the picture. And our team is a little bit of each. So our sleep department has one of each for representation and for the benefit of our patients, so we can refer them accordingly.
Okay, that's great. Another question I had is if you'd like to share some specific medications for patients and or doctors to be aware of that tend to cause that might be a cause of their sleep issues.
Well, one of the main ones that I will mention is beta blockers. Beta blockers is like atenolol, propanolol. Those are medicines that are very commonly used by cardiologists to maintain good heart rates and for blood pressure purposes. And they can do a lot of problems with nightmares, for example. That will be something to consider. There are diuretics, obviously, that are used to make patients go to the bathroom. If taken at the wrong time, can make you go up all night long to go to the bathroom. So by changing the schedule could be a simple solution. There are some medications that are used for depression, that SSRIs type of medicines, that can affect the amount of REM sleep that we get, and could affect adversely restless legs, for example. So those are quick examples of very commonly used medicines that can exacerbate. For example, if I take Zoloft, which is a brand name for an SSRI, my restless legs can really get bad. And if you didn't know that you had restless legs, you wouldn't know why your sleep suddenly got worse. Zoloft is a great medicine, don't get me wrong, but without that, you may be hurting yourself. And then benzodiazepines are perhaps one of the most common medicines used for anxiety, can affect adversely sleep apnea. Because they are sedatives, they affect the way the throat relaxes at night and can make your apneas worse. So those are quick things to keep in mind.
Okay, thank you. And I'll ask you one last question, and that would be medications that people use for sleep, either over-the-counter medications or people that try melatonin. What are your thoughts on those?
I'm okay with melatonin if it's used appropriately. Melatonin tends to have the majority of its benefit when it comes to realign the circadian rhythm, not so much for insomnia. So I use it very early, and I tell my patients that have trouble falling asleep to take it around 7 or 8 p.m. Many of my patients come in taking tons of melatonin. I don't think anybody needs 10, 20 milligrams. Usually 1 to 5 milligrams should be enough. What I don't like is using antihistaminics as an over-the-counter medicine for insomnia. In general, they produce some drowsiness, and they're used by patients commonly. I don't like their effects on the brain, and I really don't recommend it. Melatonin, I think, is a safe supplement.
Okay, well, thank you very much. That's good to know.
Yeah.
So, were there any parting words that you wish to share with our audience? And also, how can our listeners get in touch with you?
Yeah, so I think that, just to close it up, I think one of the main messages is don't be afraid of coming to the sleep consultation. You're not going to be sent into a sleep lab in an obscure area where they're going to be attached to wires and all those things that I hear. We are pretty much about talking, getting a history, making a diagnosis. Is that way we can help you and help your doctors, with your condition. And usually things get better after your sleep gets better. Your blood pressure, diabetes, you lose weight easier. So I think fibromyalgia and chronic pain, all of those things can get better. We will partner up with your doctors, and we will look for solutions that are simple, easy, testing for sleep is so much easy these days. We have so much better equipment that we didn't have before that can make it so easy and friendly. And I think that a lot of times patients don't come in because they're worried that we're going to give them another pill. And many of us are the complete opposite of that. If anything, I try to get rid of medications or replace them for your benefit and for your sleep benefit. So anybody can get a hold of me by calling my office and Nuvan's Pulmonary Medicine at 203-739-8330. We are a group of doctors that all of us see sleep disorders, and 4 of us are sleep boarded, so that we have plenty of expertise and availability to see you at any time and answer questions. And if other people can reach through you and they want to ask questions, I'll be more than happy to answer them as much as I can personally or through you.
Okay, well, absolutely. Well, thank you very much. And I love those last things that you spotlighted, because whether it's a doctor or another patient, they might have thought, which I might have too, is if somebody comes to see you, you're going to do the thing. They have to go to the hospital, be hooked up to the wire. So to dispel that myth, and also adding another medication. Some people, whether you're a doctor or a patient, don't want to add another medication. So for you to discuss those things and kind of expel those myths is terrific.
Yes,
So
yes.
thank you very much.
You're very welcome, Kim. And I hope this is useful for patients and doctors. And please don't hesitate to call me anytime and reach out.
Okay, that's fantastic. Fantastic. Well, I appreciate you very much. And in closing, to move the needle in healthcare, we all need to raise our voices and we all need to care about each other. We already know that doctors need to care about patients. Patients need to care about doctors too. So stand up, doctors, and let's stand up for doctors.
Thank you, Kim.
You're welcome.